My name is Michael Battelle, and I am the president and founder of the Fatty Liver Alliance. We raise awareness about the risks, causes, and complications of fatty liver disease and help those already diagnosed with NAFLD and NASH by advocating for access to approved treatments and care. A huge thank you to Sonic Insights, the makers of VeliCure, which is the first liver assessment tool with S-Wave technology, which is a new generation of elastography. And thank you for sponsoring this super informative webinar today with Dr. Naim Alkhouri, who's the Chief Medical Officer and Director of the Fatty Liver Program at Arizona Liver Health. Naim, let's jump right in because we would all love to hear more about the important and very relevant topic of alternative therapies for NASH. Naim?
Thank you so much, Michael, for the kind introduction, and thank you for everything you're doing for our patients with NAFLD and NASH. I also want to thank Sonic Insights for sponsoring this webinar. This is very important to raise awareness, and we all need to work as a team to make sure that we diagnose patients early and modify the course of this disease. With this, I'm going to tell you about alternative therapies for NASH, things that you can do today and things that you'll be able to do in the near future. These are my objectives. So I'm going to discuss the goals for NASH management and the effects of weight loss on the outcomes. And then I will describe the spectrum of weight loss approaches for the management of NASH, including anti-obesity medications and digital therapeutics. And then I will also discuss novel therapeutic agents in development for NASH. You can follow me on Twitter. And if you're interested in watching liver videos, you can also follow us on TikTok. So first, I wanted to provide you with updated data on the prevalence of NAFLD and NASH. This is from a paper that we just published last year in the Journal of Hepatology with my collaborator, Dr. Stephen Harrison, where we looked at a cohort of middle-aged Americans coming for screening colonoscopy without any known history of chronic liver disease, elevated liver enzymes, or excessive alcohol consumption. And we offered them to have a comprehensive liver assessment. If they agreed, we did a state-of-the-art MRI PDFF to quantify liver fat. And if they had more than 5% liver fat, we diagnosed them with NAFLD, and then we offered a liver biopsy to diagnose NASH, non-alcoholic steatohepatitis, the aggressive form of NAFLD. And what we found that in middle-aged Americans living in San Antonio, Texas, 38% were affected with NAFLD, so this is higher than previous estimates. And more importantly, 14% of the total cohort were affected by NASH, the aggressive form of NAFLD. The prevalence in certain subgroups in this study was even higher. So when we looked at Latino, Hispanic patients, 55% had evidence of NAFLD and 25% had NASH on biopsy. When we looked at patients with type 2 diabetes, 70% had NAFLD and 36% had NASH. And then if you look at individuals with multiple risk factors, so Hispanic with obesity and diabetic, it's almost a given that they have NAFLD at 92%, but almost half had NASH, the aggressive form of NAFLD. So we need to really start thinking about screening for NAFLD and NASH in high-risk groups, such as patients with type 2 diabetes, especially from a Hispanic ethnicity. We also published a paper this year looking at a nationally representative database called the NHANES database, where thousands of individuals had FibroScan testing done to assess for liver fat on the CAP score. We used the threshold of 302. And then you can also assess for liver fibrosis based on the vibration controlled transient elastography measured in kPa. And in the general adult population, we found that NAFLD affected 25%, but importantly, about 3% had evidence of advanced fibrosis or cirrhosis, so very concerning. And then when we looked at patients with type 2 diabetes, 55% had evidence of NAFLD, but even more importantly, about 12% had evidence of advanced fibrosis or NASH cirrhosis. So we have a problem. Winter is coming. We estimate that we have 75 million individuals with NAFLD in the United States, and we only have 7,500 providers in the US that take care of liver patients. This includes hepatologists, APPs with interest in hepatology, and gastroenterologists that are focused on liver disease. So we definitely need help. The good news is that we have several ultrasound-based radiologic tests that can screen for NAFLD and identify high-risk patients. I mentioned FibroScan, measuring transient elastography, VeloCure that Michael mentioned earlier. This is a new technology where you induce shear wave by placing a board under the patient, and you actually do 3D measurements of liver fat and liver stiffness. So you have a large volume of the liver that you are looking at. And there are other ultrasound-based technologies like acoustic radiation force impulse and shear wave elastography. So moving on to the management piece, what are the goals for NASH management? Well, number one, we want to achieve liver-directed outcomes. So we want to see NASH resolution, fibrosis regression. But equally important, we want to treat the metabolic syndrome and cardiovascular disease. So we want to optimize diabetes management, dyslipidemia, hypertension, chronic kidney disease, because these comorbidities contribute to the progression of NAFLD and NASH. And if we don't control them, these patients will have worse outcomes. And then, of course, we want to achieve weight loss. Obesity is the main cause of metabolic syndrome and NASH. And if we induce weight loss, we expect better outcomes. But what matters most to the patients is really having longer life and having better quality of life. And if you look at what kills patients with NAFLD, we know that cardiovascular disease is the #1 killer. And in this study, when you look at patients with F3 fibrosis compared to patients with F4, which is cirrhosis, we see clearly that major adverse cardiovascular events are the #1 cause of death. And then when you look at patients with NASH cirrhosis, this is when we see major adverse liver outcomes taking the lead as a cause of death in these patients with NASH cirrhosis. So ideally, any treatment we have will lead to improvement in cardiovascular events and also reduction in major adverse liver outcomes. Now, weight loss through lifestyle modifications work. We have several studies, including a randomized controlled trial from Cuba, showing that if you lose 7% of your total body weight, you will see NASH resolution in the majority of patients. And then if you achieve that 10% total body weight loss, you may see fibrosis regression. This translates for someone who's 200 pounds into losing 20 pounds, which is, it sounds achievable, but even in the context of clinical trials, only 10% of individuals are able to lose that 10% total body weight loss. So we need help in addition to lifestyle modification. How about bariatric surgery? Can we reverse NASH with this? And we have nice data now from France where they followed a cohort of 180 subjects that had NASH at the time of bariatric surgery on biopsy. And then they did biopsies at 1 year and 5 years after the surgery. And if you look at the 5-year data, 85% achieved NASH resolution. And the rate was higher according to the percentage of BMI loss. So the more weight you lose, the more likely you will achieve NASH resolution. There's data on fibrosis regression, which is great. So bariatric surgery works, but it's costly, and the acceptance rate is still low by patients and insurance companies. And now I want to share data with you on long-term outcomes with bariatric surgery on patients with NASH. This is from a paper that we published last year in JAMA called the Splendor study. This was a retrospective study. Patients had biopsy-proven fibrotic NASH, so NASH with F1 to F3, but no cirrhosis. And we had a cohort that had bariatric surgery and a control cohort. And the primary endpoint was really major adverse cardiovascular events and major adverse liver outcomes, because we felt that these are the two most important outcomes for our patients. And here you can see that we had 650 patients that underwent bariatric metabolic surgery and 500 non-surgical control. They were fairly balanced in terms of age, gender, percentage diabetics, smoking, disease activity. But of course, the metabolic surgery cohort had higher BMI. And this is what we showed in the study, that if you follow these patients long enough, up to 10 years, there's clear separation in terms of major adverse cardiovascular endpoints, with the bariatric surgery having favorable outcomes. We actually showed reduction by 70% in developing MACE. So significant reduction with bariatric surgery. And for the first time, we are showing that there is an intervention that can decrease major adverse liver outcomes. So when you compare the surgery group to the non-surgical controls, there was reduction in these outcomes by 88%. These outcomes include development of ascites, hepatic encephalopathy, variceal bleeding, needing liver transplantation. So very important outcomes. So again, bariatric surgery works for sure, but unfortunately, it's not done in a high percentage of patients with NASH, even when they have advanced fibrosis. How does bariatric surgery work? At the end of the day, it is weight loss. You see significant weight loss in the bariatric surgery group in the 20 to 25% change in weight. And then, of course, improving the metabolic parameters, so significant reduction in A1C. Typically, there's also improvement in dyslipidemia. So if we can achieve these outcomes with weight loss and improving insulin sensitivity with lifestyle or medications, we may actually achieve the same outcomes we see with bariatric surgery. So when we talk about weight loss, it's not only lifestyle intervention and bariatric surgery. In between, there is medications, pharmacotherapy, what we call anti-obesity medications. And these are endorsed by several professional societies. And in the United States, we have 6 anti-obesity medications that are approved by the FDA and available to be used today. And we expect to have a few more in the next couple of years. The ones that we have today include orlistat, phentermine in combination with topiramate, naltrexone in combination with bupropion, liraglutide, the GLP-1 agonist, and then semaglutide, 2.4 milligrams, the high dose GLP-1 agonist. I consider semaglutide the second generation GLP-1 agonist, better efficacy. In terms of the effects of anti-obesity medications on NAFLD and NASH, we have some data on histologic improvement, mainly on NASH activity improvement, the reduction in liver fat on imaging, and then improvement in serum biomarkers. But if you dig deeper into the data, you realize that we don't have any convincing data on fibrosis regression with anti-obesity medications. Maybe it's related to the duration of follow-up. Maybe with the older anti-obesity drugs, we were not hitting that 10% threshold. So we will learn more as we develop newer medications for obesity. Now, this is what I do in my clinic when I think about weight loss management of patients with NAFLD. I look at the BMI, I look at the presence of type 2 diabetes. If the BMI is overweight, obese, but less than 35, and they don't have diabetes, we start with lifestyle intervention. Typically, we recommend a low glycemic index Mediterranean type diet for long-term maintenance. But if I see patients with BMI above 35, they have type 2 diabetes, they're struggling to lose weight, I try to implement anti-obesity medications early on, always in conjunction with the lifestyle intervention. But we should not wait. We should not deny these patients the anti-obesity medications and then let them fail with lifestyle alone. And then they get frustrated. Sometimes we lose them for follow-up. So it's good to be aggressive early on. If the BMI is more than 40 or they have several other comorbidities, bariatric surgery should be considered early on. But you can also use it when you fail with anti-obesity medications. Now, how about the persistence of these anti-obesity medicines? Do actually patients take them, and do they stick by them and take them for years? This is a paper from a large claims database, over 25,000 individuals that were prescribed anti-obesity medications. Here you see lorcaserin, which is no longer available, liraglutide, naltrexone, bupropion, and the last medicine is phentermine topiramate. And this is what happens in the real world. So you can see that, yes, you start these medications from day one. Many patients do not even fill one prescription, but even when they start taking them, if you follow them to 15 months, you can see that with the oral medications, less than 10% were still actually taking them. The blue bar represents liraglutide, which is an injection GLP-1 agonist, and about 26% only were still taking it. So this is really alarming. I've witnessed this in my clinic. I think it has to do with no great results on weight loss and then potentially side effects. The fact that more patients were taking the injectable tells you probably that liraglutide was working better for them in terms of inducing weight loss. So how about the second generation GLP-1 agonist, semaglutide? Here I'm showing data from the STEP 1 trial. This was a large study, almost 2,000 adult patients with obesity and no type 2 diabetes. They are treated with semaglutide versus placebo for 68 weeks. And what we showed here is with semaglutide, there is significant and sustainable weight loss. So by week 68, you can see it's about 16, 17% weight loss in terms of change from baseline. And this was significantly better than placebo. And if you look actually to the graphs on the right, you can see that the majority of patients, when they use semaglutide, achieve that 10% total body weight loss. So about 70 to 75% compared to only 11, 12% with placebo. And this is the threshold that is known to be associated with NASH resolution and fibrosis improvement. So very promising data with semaglutide. And this is data from the SUSTAIN 6 trial that looked at cardiovascular outcomes in patients with type 2 diabetes who were treated with semaglutide versus placebo, showing clear separation and that semaglutide was superior to placebo in preventing cardiovascular outcomes. So this is very important in our patients with NAFLD. And of course, there's improvement in A1C and body weight with semaglutide compared to placebo. So this is great. Now we have a drug that can induce weight loss, can improve insulin sensitivity, and has cardiovascular outcome data in patients with type 2 diabetes. So you can see that we are hitting on many of these goals for treatment that I mentioned earlier in my talk. Tirzepatide is a new GLP-1 GIP agonist. There's a new paper published in the New England Journal of Medicine called the SURMOUNT-1 study. This was done in an obese population, showing very great efficacy in the 22% total body weight loss. So more to come on using GLP-1 agonist, maybe in combination with other agonists like GIP. The issue with these medications, at least with semaglutide, is that there is weight regain if you stop the medications. So this is data from the STEP 1 trial extension arm. This included 327 participants that were in the STEP 1 initial trial, but then they were followed for an additional 52 weeks after they stopped semaglutide. And what happens if you stop semaglutide? This is the reality. So you can see in the graph, first we showed the data from the original STEP 1 study. They lose significant amount of weight, 17%. But then within 1 year after you stop, you regain about 2/3 of weight. So we need to change how we think about these medicines. They're not something we're going to use for a few weeks or month and then you stop. We need to think about treating obesity the same way we treat dyslipidemia and hypertension. We don't control the cholesterol and stop the medicine. We keep you on the cholesterol medicine to maintain that control. Also concerning is that, when you stop the medicine, you see a rebound in the A1C, blood pressure. So it seems like you lose the other metabolic effects that you see with semaglutide. So again, the message here is that maybe we need to maintain therapy. Are there other ways to help us maintain weight loss? I see an opportunity here for what we call prescription digital therapeutics, or PDTs. These are basically software or phone apps that will be prescribed by a physician. They will undergo a rigorous evaluation process by the FDA, where you have to do randomized controlled trials and show that they work better than a sham app. and then you get an FDA approval, and then the idea is that they will be covered by insurance companies. So again, you'll go see your doctor, they will prescribe you an app, you get it authorized by your insurance, and then it will be covered, and it will help you with different diseases, from type 2 diabetes to inflammatory bowel disease to potentially weight loss and NAFLD. And this is important to understand, that not all apps are created equal. So we have apps that are meant to improve overall well-being. Some of them are for meditation or to track your fitness. We have apps that have a specific goal. For example, Noom is targeting weight loss, but this is not considered a prescription digital therapeutic. This is something that you sign up for, and then they provide you with their cognitive behavioral therapy based technology to help you lose weight. And then the highest tier apps is really what we call prescription digital therapeutics. These will undergo that evaluation by the FDA. They'll get FDA approval, and they have to be prescribed by a physician, monitored by a physician, and the insurance companies hopefully will cover them for our patients. So just wanted to share some data with you on what's happening with prescription digital therapeutics. This is data with Better Therapeutics. They have an app called BT001, and they actually did a randomized study in almost 670 patients with type 2 diabetes. They were randomized to the BT app versus a sham app for about 6-month period. And the primary efficacy endpoint was change in A1C. And then, of course, they looked for safety and other secondary endpoints. And what they showed is that with the BT app, there was reduction in A1C by 0.4 percentage points or more in 42% in patients receiving the app, versus only 25% if you are receiving standard of care alone with the sham app. This was significantly different. Again, the difference was at 17%. And with these apps, you can track engagement. You can see how many minutes they spend each day on the app, how many articles they read, how many exercises they looked at, and they showed a clear dose response between greater engagement with the app and greater reduction in A1C. So this is very encouraging data in the context of type 2 diabetes. Now, this is what I call the weight management spectrum for NAFLD, and I think we need to utilize all these tools. So number one is we have traditional lifestyle interventions, could be done with a registered dietitian. We will also have all these digital tools, including prescription digital therapeutics. We have anti-obesity medications. Some are oral, some are injectables. We are seeing better success now with injectable medications. We have also a list of what we call endobariatric procedures. These are done endoscopically, so it's not surgical. You can place a stomach balloon. We can do mucosal resurfacing of the duodenum. There are, procedures where you can do endoscopic sleeve gastrectomy. So very exciting field. We need more data in NASH, but the data is starting to emerge, and there are several randomized clinical trials in preparation. And then we have also bariatric surgery. And again, I think I showed you convincing data that bariatric surgery is a good option for patients with NASH and significant fibrosis, but the acceptance rate is still not where we want it to be. How about novel therapeutic agents in development for NASH? What's in the pipeline? What's coming next? Luckily, we have a rich pipeline, and we can target the pathogenesis of NAFLD and NASH at each step. So we have medications that can target insulin resistance and lipid metabolism and help with weight loss. There's a long list of these medications, and you can see here semaglutide and resmetirom are listed there because in red, these are the ones in phase 3 clinical trials. We have medications that can target lipotoxicity, oxidative stress, bile acid synthesis, and many of these drugs have pleiotropic effects. But here I'm listing lanifibranor and obeticholic acid, or OCA, as drugs in phase 3 clinical trials. We have medications that target liver inflammation and immune activation. We have medicines that target hepatocellular death and try to modify apoptosis and necrosis in beneficial ways. And then we have anti-fibrotic drugs, and these are medications that will hopefully lead to fibrosis regression. We may have to use them with other metabolic drugs so we can target upstream and downstream. But at the end of the day, with any therapeutic intervention, the holy grail and what we want to see is our patients achieving fibrosis regression and then avoiding the development of cirrhosis and major adverse liver outcomes. So in the next few slides, I just want to give you a brief overview of the 4 agents that are in phase 3 clinical trials. The first agent I want to discuss is resmetirom. It used to be called MGL3196. This is what we call a selective thyroid hormone receptor beta agonist. So we know that if you give a patient with NAFLD thyroid hormones, they will lose weight and you can defat the liver and you may improve their lipid panel. The issue is thyrotoxicosis. They will have increase in heart rate, cardiac arrhythmias, bone loss. So that's why we do not utilize thyroid hormones. Well, it turns out that the thyroid hormones signal through 2 nuclear receptors. Nuclear receptor alpha is responsible for thyrotoxicosis, and then the thyroid hormone receptor beta is the one mainly responsible for the beneficial metabolic effects. So again, resmetirom is a very liver-targeted selective thyroid hormone receptor beta agonist, and the idea is that you should see improvement in lipids and defatting in the liver and improvement in NASH. So this is data from the phase 2b trial that we published in Lancet in 2019, looking at reduction in liver fat after only 12 weeks of treatment with resmetirom. And if you focus on the high dose resmetirom, there was 42% relative reduction from baseline in terms of liver fat measured by MRI PDFF. We've learned from previous studies that if you reduce liver fat by 30% or more from baseline, this corresponds with improvement in NASH and reduction in the NAFLD activity score. And in this phase 2b study, we showed that 75% of patients treated with high dose resmetirom were able to achieve that threshold. If you look at NASH resolution on biopsy in patients that reduced their liver fat, this was significantly better with the high dose resmetirom at 39% compared to placebo. So a promising agent that's in phase 3. We expect the readout of the Maestro NASH trial at the end of this year. And if that trial is positive, meeting the efficacy endpoints, we can potentially see this drug FDA approved next year. The second drug I want to mention is lanifibranor. This is what we call a pan-PPAR agonist. And PPAR alpha is really the target for fibrate medications. So its main function is to reduce lipids, especially triglycerides. So lanifibranor has PPAR alpha activity. PPAR gamma is the target for the glitazone medications. These are diabetes, insulin sensitizing medications. So lanifibranor has also PPAR gamma activity. And then there's PPAR delta, which has liver-targeted effects. It has anti-inflammatory and potentially anti-fibrotic effects, and it has also other pleiotropic effects in other organs. So lanifibranor targets all 3 PPARs, alpha, delta, and gamma. And in a phase 2b study that included about 250 patients with biopsy-proven NASH and fibrosis, we published this paper last year or 2 years ago in the New England Journal of Medicine. With the high dose lanifibranor, 1200 milligrams daily, there was resolution of NASH and no worsening in fibrosis in 45%, significantly better than placebo. There was also regression in fibrosis by 1 stage in 42% with the high dose lanifibranor. And then if you look at achieving both endpoints, resolution of NASH and regression in fibrosis, that was achieved in 31% with the higher dose, significantly better than placebo at 7%. So another promising agent. Semaglutide that I discussed earlier for obesity and type 2 diabetes, it's a GLP-1 agonist. This was a phase 2b study that included about 270 individuals with biopsy-proven NASH. We had different doses with semaglutide. But I think the high dose was the most effective, so I wanted you to focus on this. And this would be the equivalent of using semaglutide 2.4 milligrams weekly, which is the dose indicated for obesity today and is FDA approved at that dose. So again, patients had biopsy at baseline. They were treated for 72 weeks and had repeat biopsy. And if you look at the high dose semaglutide in the dark blue, they achieved NASH resolution in almost 59%, and this was significantly better than placebo. So very encouraging data. We know that this medicine will lead to weight loss, improvement in insulin sensitivity, and potentially with longer follow-up, we may see improvement in cardiovascular outcomes. There was no clear regression in liver fibrosis in this study, so we may need longer duration to be determined, but this is important to follow up. And finally, I want to share data from the Regenerate study. This was evaluating obeticholic acid, which is a synthetic bile acid that functions as an FXR agonist. FXR is a nuclear receptor that senses bile acids and then can regulate bile acid synthesis and function. So this is actually a phase 3. It was a baseline biopsy showing NASH with fibrosis and then repeat biopsy at 18 months. This was the interim analysis looking at histology. What we showed is that there was actually improvement in fibrosis with the high dose obeticholic acid 25 milligrams at 23%. And this was significantly better than placebo at 12%. There was no NASH resolution with OCA that was better than placebo, but definitely they met the primary endpoint on fibrosis regression. I think this is a high bar to achieve after only 18 months of therapy, especially in a large phase 3. So the data is convincing that obeticholic acid has anti-fibrotic effects. But obeticholic acid has adverse events, including pruritus in 50% with the high dose 25 milligrams. There was also, unfortunately, worsening in lipid profile, increase in LDL cholesterol and decrease in HDL cholesterol. Many patients were started on a new statin, or their statin dose has to be increased during the trial. There was also signal on cholecystitis and potentially hepatotoxicity. So because of the relatively smaller delta between obeticholic acid and placebo on fibrosis improvement and the potential for these adverse events, they did not get FDA approval. However, obeticholic acid has more data now in the same trial where they continue to follow patients for safety and outcomes. And they did a reanalysis of the histologic data by having consensus pathology reading showing same efficacy on fibrosis regression. So this might be a good drug that we utilize in patients with F3 fibrosis if we end up getting FDA approval. You may hear about this also in this coming year. So exciting things that are happening in this space. I think the two front runners are resmetirom, a thyroid hormone receptor beta agonist, and obeticholic acid, which is a synthetic bile acid that functions as an FXR agonist. Now I want to introduce you to the NASH drug scorecard. This is something that we developed and published last year because we anticipate that we're going to have several drugs on the market for NASH. This is the dream scenario for me, to have multiple drugs to choose from and get to the concept of personalized medicine and how we utilize these NASH drugs. So when you are evaluating any NASH drug, we have to look at three major areas. Number one is what's happening with liver efficacy endpoints. What percentage NASH resolution we're seeing, and what's the delta from placebo. Second is what's happening with fibrosis improvement. How many patients are achieving that one fibrosis stage regression at the end of treatment. And it's also important to look at other biomarkers like reduction in liver fat on MRI-PDFF, improvement in liver enzymes, maybe other non-invasive tests that will assess for disease activity and liver fibrosis. But we should not be just focused on hepatic efficacy endpoints. It's very important that we look at the metabolic syndrome components. So when we use a NASH drug, what is happening to their weight. I highlighted weight because this is very important to achieve weight loss ideally. Some medicines will help you lose weight. Some medicines are neutral on weight. And some medicines, although they have great hepatic efficacy endpoint, may make you gain weight. And, in that scenario, we need to think about strategies to mitigate that weight gain because we want to also keep the good hepatic outcomes. We need to also look at lipids and see what happens to your LDL, HDL, triglycerides. I showed you examples of medicines like resmetirom that can help dyslipidemia and examples of medicines like obeticholic acid that can make it worse, and you have to mitigate this with using statins or increasing the dose of statin. And that's justifiable to keep the liver outcomes, but it's very important to think about it early on. And then we also need to think about what happens to insulin resistance. Are we helping with A1C, especially in patients with type 2 diabetes? Now, long-term outcomes are very important also, but that will take probably a few years before we had that kind of data to compare. But it's very important to see what happens to cardiac outcomes and major adverse liver outcomes eventually with these medications. And these could become differentiating points when we choose a drug versus another. And then the third area that we need to look at with every drug is adverse events. And we have what we call adverse events of special interest. For example, pruritus with the obeticholic acid, the GI adverse events with GLP-1 agonists. So we have to take these into account before we start a drug. So if I have a patient with type 2 diabetes and severe gastroparesis, and their main issue has always been nausea and vomiting, and this is limiting their quality of life, maybe I'm not going to start a GLP-1 agonist. You'll be surprised that many patients with NASH have pruritus at baseline, and they may have significant cardiovascular history. So that may temper my excitement to start obeticholic acid in someone. So this is what we need to do when we decide on which medicine to use. And the next table here, I'm just providing a preliminary comparison of the 4 drugs that are in phase 3 using the NASH drug scorecard. So again, what data do we have on hepatic efficacy endpoint? What data we have on the metabolic syndrome with the focus on weight loss? And then what are the major adverse events of special interest with these medications? I have question marks because sometimes we have concerns based on animal data or maybe using similar drugs in the same family, but not the exact same medicine, and just being in the same family of medications or having maybe a shared mechanism of action doesn't always translate into developing the exact same adverse events. This is, again, very preliminary comparison based on different trial designs and based on preliminary data, but it's just to show you how you can utilize this card to assess different medications. Again, the goal is to hopefully have multiple options for our patients in the near future. So my take-home message is really that we have several anti-obesity medications that are currently available to help our patients with NASH in conjunction with lifestyle interventions. Unfortunately, the oral ones that we have today, they have relatively low efficacy in terms of the percentage total body weight loss and also low adherence by our patients. So we need newer medications. We are seeing great data now with the GLP-1 agonist and the newer GLP-1 GIP agonist. The weight loss is there. We've never seen this with the pharmacologic treatment in the past, so this is very encouraging. But we need to realize that these are not magic injections. It's not something you're going to use for 6 or 12 months and then stop and maintain that weight loss. Weight regain is a major challenge. And we've seen also the loss of some of the beneficial metabolic outcomes, including, once you stop the medicine, worsening in A1C. I think there is room for other innovative approaches to help with weight loss, including prescription digital therapeutics. I see these as more of a companion to anti-obesity medications and in the future NASH medications, but they may help you, start the weight loss journey. They may help you also maintain the weight loss that you achieve with anti-obesity medications. There are other tools that I discussed, including bariatric endoscopic procedures, and then, of course, bariatric surgery. I think patients with NASH today have many options to get the help that they need. So I think screening high-risk individuals, identifying the severity of the disease is of paramount importance today. I don't want us to treat this disease with apathy and feeling like, well, the only thing we have to offer is lifestyle interventions. Lifestyle intervention is the mainstay of treatment. It should always be offered with any other intervention, but we need to be more aggressive with anti-obesity drugs, utilize the drugs that we have today to optimize also diabetes management. I didn't have time to mention the use of vitamin E and pioglitazone also for NASH, but these are options that you have available to you today. And I want to end this with the message of hope that in the near future, hopefully our patients will have several NASH-specific drugs that are approved by the regulatory agencies to choose from. We need everything we have in our armamentarium to fight this illness. Here I have, the Texas food chain showing you all the delicacies that I used to enjoy when I lived in San Antonio, Texas, and we have many of these in Arizona today. So, this is trying to be funny, but also to tell you that, this is bigger than our patients. We need to support them, let them know that this is a society problem. This is, again, not their fault, and that weight loss is a very difficult journey, and that we need to utilize all the tools that are available to us. So with this, I'm going to conclude the slide portion of this presentation and hand it back to Mike to go over the Q&A session, and hopefully you guys will have many questions. Thank you so much.
Well, Naim, that was fabulous. I'm almost speechless because you covered so much and talked about so many important issues, particularly at the end, your plea to everyone to take this seriously. So I personally really appreciate that. We have a question from one of the attendees. When should we expect phase 3 data from resmetirom? Is it going to be the ASLD, or do you think before that?
Yeah, I mean, I think, as you know, with the meetings, you have to submit the abstract. So the late breaking abstract deadline has passed. So I don't think we're going to see the presentation at ASLD, but I think by the end of this year, we will have that, initial data and press release. So before the end of this year, you will hear about resmetirom and the data of the Maestro NASH phase 3 trial. Now, I didn't have time to go over another phase 3 trial that was completed with resmetirom. This is the Maestro NAFLD trial, where we included patients with NAFLD and evidence of metabolic syndrome as well, and we showed a significant reduction in liver fat on MRI-PDFF, improvement in ALT, and some encouraging data with other biomarkers like reduction in liver stiffness on FibroScan, and also a signal in liver stiffness on MR elastography. So very encouraging, also encouraging data on improvement in dyslipidemia. And this was a large phase 3 trial. We also have an open label study in patients with NASH cirrhosis. So very encouraging data, but I think in terms of FDA approval, we are eagerly awaiting the Maestro NASH trial, and this will be before the end of this year.
Okay, thank you for that. A couple more questions coming up here, and thank you for sending them to us through the Q&A tab. So Naim, and I thought about this as one of my questions I was going to have for you too. Do you think that there's not going to be one single pharmacological solution, that in fact it may be a combination of therapies as opposed to a monotherapy to resolve NASH?
Yeah, my favorite topic. I do believe that the management of NASH is going to evolve in a similar way to the management of type 2 diabetes, where combination therapy will definitely play a role. I think initially it will depend on several factors, including where the patient is at on the disease spectrum. So I see a scenario where we have patients with early disease, maybe NASH with F1, F2, where we start with monotherapy and reassess. And if we see see great response, maybe that's all they need. But if we see that they're responding, but it's not adequate response, we add on another therapy. And that's what we do for patients with type 2 diabetes. If the A1C is at 7, let's say, right? We start monotherapy, then we add medications. And then we have patients that will show up maybe with F3, they're on their way to F4, and I don't feel like we have the luxury of time to treat for 1 year with one agent and see what happens, and they may end up in cirrhosis. So these patients, maybe if I have 2 drugs to choose from, I'm going to hit them hard with combination therapy. And then if we achieve great outcomes and we see regression, maybe after a couple of years, maybe we can de-escalate therapy and move on to just a single agent. And this is what we do with type 2 diabetes. If you show up with an A1C of 11, no endocrinologist or PCP is going to just start you on metformin and wait and see what happens. They will start you on combination therapy and then get you under control and then reassess. So I see combination therapy being part of the future for sure. Are we going to need it for every single patient? Maybe not, but I can see a very good percentage of patients not being able to be salvaged with monotherapy where we have to use combination therapy.
Okay. We have questions coming in, so I'll get through them to those who sent. Thank you. There are about 10% of patients, as you know, that are labeled as lean NASH patients. You didn't have a chance to touch on that, but how would you approach treatment with them?
Yeah, this is a very timely question because the American Gastroenterology Association just published a new guidance document on how to manage lean NAFLD, so I encourage you to read it. The idea here that many of these individuals actually have some components of the metabolic syndrome, so they are lean based on the BMI definition, but they may have prediabetes, insulin resistance, sometimes full-blown diabetes, dyslipidemia, and I think it's very important to optimize the management of the metabolic syndrome. I think it's very important to realize that they can also progress to NASH with advanced fibrosis and even NASH cirrhosis. So it's very important to determine the severity of their disease. It seems like modest weight loss is also beneficial, especially if the BMI is borderline overweight. You know, your BMI is 24.5. So maybe targeting 3 to 5% instead of 7 to 10% is beneficial. We have data showing that exercise, any type of exercise, will be helpful, whether it's aerobic or resistance exercises. And then, you know, there is some data on utilizing some of the medicines that we have, and we will have more emerging data on this population with the new therapeutic agents. So again, I think the message is that there's a lot to be done today for anyone with NASH, including lean NAFLD. Optimize the management of metabolic syndrome, determine the severity of their disease, modest weight loss, increase exercise, and if you need to use medicines, you can consider them, such as vitamin E or pioglitazone.
Thank you very much for that. What about glutathione? Will that help with NASH?
Yeah, so that's an antioxidant, and there are, you know, ongoing studies now. In terms of the mechanism of action, I think there's a good rationale, but there's no convincing data now in randomized controlled trials that you can utilize this as a treatment for NASH. So this is where we stand on glutathione, but maybe more data will emerge in the future. It may not be adequate by itself. It could be something that we develop in combination with other agents. We'll see. This is, you know, to be determined in the future.
Okay, thank you. I want to talk about weight loss. You stress that that's one of the key factors in success here, because it's a really obesity is tied in with, obviously, with diabetes, type 2 diabetes, and other metabolic risk factors. So you also said at one point that there's only about a 10% success rate for people that lost weight. So what would you say to people as a first approach? Does it go back to like improve your diet and exercise more as a first line and then see what happens, or what would you say?
No, I think my message is that we need to be more aggressive with this. If you are seeing a patient as a liver specialist for the first time for NAFLD, but they've had type 2 diabetes for 10 years and they've been told to lose weight for the past 10 years, and they tell you my weight has been the same. I think it's, not a good idea to say, well, try one more time. What's going to change? I don't see them succeeding. I think this is the time for us to be more aggressive and say, I realize you've tried, this is not your fault. Weight loss is very difficult, so I'm going to get you on the medicine. In my mind, today we have three effective options that make people lose significant amount of weight. Number one is bariatric surgery. Number two is semaglutide, which you can use for obesity. Number three is tirzepatide, which is FDA approved for type 2 diabetes. But if you have someone with type 2 diabetes, obesity, it's a great drug. The other medications such as phentermine in combination or alone, unfortunately, again, the weight loss is not significant. The persistence with these medications is very low. They may help some individuals, so I'm not, taking them out of the equation, but I think I would encourage providers to become more familiar with prescribing GLP-1 agonists for obesity, optimizing type 2 diabetes. This is something I do routinely in my clinic. And I think hepatologists are used to using drugs like interferon and liver cancer therapies. So we have high tolerance for managing adverse events. But I do encourage my gastroenterology colleagues to become familiar with GLP-1 agonists and utilize them in the appropriate patients. Endocrinologists do this routinely. PCPs are very familiar now. But if you can help your patients with NASH lose weight with these agents, they have that FDA indication. I highly encourage them to utilize them. So we need to be aggressive, and we need to talk about bariatric surgery early on, especially if they have multiple comorbidities, diabetes, obstructive sleep apnea, heart disease, and NASH. I think this is something that can manage potentially all of these complications, or at least lead to some improvement.
Now, Naim, I shared this with you once before. My daughter was obese and had other comorbidities. Got to the point where she lives in California. She went to Magic Mountain once, couldn't do up the seatbelt on a roller coaster ride, and for her that was it. She needed to find a solution, and the other weight loss programs in the past were not successful. She had gastric bypass, and she went from 256 to 130, and literally a new person, and healthier and happier. And I just wanted to say, I think we should consider that. It's a serious decision, but it's very helpful for some patients.
Yeah, thank you, Michael, for sharing this also with the audience. This is great, and it's a success story. And I think bariatric surgery is definitely underutilized. We estimate, honestly, that our patients with NAFLD only probably 2-3% undergo bariatric surgery, even when they have a clear indication for it. One of my big frustrations in my clinic is that I identify good candidates. The patients are receptive and they realize that this is a good option. And then when we send them, they get denied by insurance. So even when they make it to a bariatric surgery program, some patients also drop out. They're not able to comply with the recommendations. It's very important to do this in a multidisciplinary team where you are also seeing a dietitian and you are seeing a psychologist, because this is a lifelong commitment. Bariatric surgery is not the end of the story, it's the beginning. And you have to have that mindset that, I'm going to implement a lifestyle intervention with my surgery that I will continue for the rest of my life. Without this, you start seeing weight regain and the complications after the surgery. So it's very important to do it in a multidisciplinary team.
Yeah, totally agree with that as well. We have a question going back to primary care setting. And could you comment on an easy to use diagnostic test that's available in the primary care setting to identify patients that are at risk of having NAFLD and NASH?
Yeah, great question. Thank you for asking. So probably the simplest test in primary care is something we call the FIB-4 index. This is available as an online calculator. You can download it to your phone, which I have on my phone. This includes AST, ALT, platelet count, and age. You put them in the equation and you get a number. If your FIB-4 is less than 1.3, this is a patient that's very unlikely to have advanced disease. If the FIB-4 is more than 1.3, this is a patient that you should consider further evaluation. There are several easy non-invasive tests that I showed, like VeloCure and FibroScan and ARFI. There are other serologic tests that can be done at a commercial lab, like the Enhanced Liver Fibrosis test or the Fibro test. But I think for primary care physician, if you want to do one thing that's simple, just calculate the FIB-4 index. Less than 1.3, you're good to keep them in your practice and work with them on metabolic syndrome, and then reassess in a couple of years. More than 1.3, if you don't have access to other tools, send to a specialist who can do further assessment.
Thank you for that. Now we're at an era, as you said before, that we're pre-pharmacological solutions at the moment, and there's a lot of obviously treatments that are in the final studies and approvals. So is there something else that patients need to do with their primary care physicians now if they're going in for their annual? Do they say, hey, I heard that because I'm overweight and because I have type 2 diabetes that maybe I'm at risk for fatty liver disease? Should they ask to be tested at this point?
I think that's a very important, point that you bring up. I think this is, if you look at the European fatty liver guidelines, they recommend that patients with type 2 diabetes should be screened. We're a little bit behind with the American guidelines, but these guidelines are being updated as we speak. So I anticipate that we will see some changes. I think this is very important for anyone with type 2 diabetes to bring up the point with your physician and say, are you checking on my liver? Do I have fatty liver? Do we know if I have advanced disease? I think the same should apply also for patients with prediabetes or metabolic syndrome. And if you are concerned about fatty liver, if you have obesity and you have a family member who progressed to NASH cirrhosis, we know that there is also the genetic component to this, and we know that family members of patients with NASH cirrhosis are more likely to have advanced disease. And there are easy ways to do this, as I mentioned. So I think it's a very important point to bring. I see a future where assessing the liver will become part of the diabetes visit. Same thing when you do the eye exam, you assess for chronic kidney disease, you do a foot exam, then you do a liver test also to assess for fatty liver. The ADA and the American Association for the Clinical Endocrinology, they recommend actually looking for fatty liver in patients with type 2 diabetes. So this is endorsed by the endocrine guidelines.
Thank you. I think we have one last question before we say goodbye. And this is a good one because it follows up on what you just said when we were talking about non-invasive testing. Do you think, and this is going to be obviously just your opinion, but do you think that we are at the point when drugs are approved by the FDA to treat NASH, that biopsies will or will not still be required for treatment? That's with regard to like reimbursement as an example.
Yeah, I mean, I think biopsy is the end point now in the phase 3 trials, because this is what we had when the FDA established the pathway to getting drug approval. But I think biopsy in clinical practice is a very invasive procedure. If we're going to use it to track how patients are responding to these drugs, it means you have to do a biopsy at baseline, maybe biopsy at 1 year and 3 years. So multiple biopsies in the same patients. In my mind, this is a very unethical approach. We have very good data as specialists to show that if you use combination non-invasive tests, that you can be very confident that you can identify advanced disease, and this correlates with biopsy findings. We are working diligently now on identifying response biomarkers to different therapeutic agents, and these data will become available when we have FDA approval. So I do not see biopsy being part of the future. I see it as a good part of the past that I'll be very happy to say goodbye to as soon as I can.
Thank you, Naim. I want to start by thanking you for, again, a fantastic presentation, very thorough. I want to thank the attendees for coming and spending their time, and Sonic Insights for sponsoring this event. On velocure.com, you can find out more about Velocure and also about Sonic Insights. There is going to be a survey at the end of this seminar, at this webinar, and I thank everybody for coming.